World Health Organization Southeast Asia region comprises of 11 countries with a population of 2 billion, and this region accounts for over 40% of the global stroke mortality. In this special issue of Lancet Regional Health Southeast Asia, in a series of systematic reviews, we evaluated the burden of the risk factors and the unique etiologies of stroke in this region. We found that there is a high prevalence of metabolic risk factors such as hypertension and diabetes mellitus. In addition, there are several uncommon causes of stroke such as dengue, scrub typhus, falciparum, malaria, snake bite, and scorpion sting.
Despite the topographic, sociocultural, and economic diversities exhibited by the Southeast Asian region, it is tied together in its commonalities when it comes to stroke burden, stroke services, user awareness, and health-seeking behaviors. In the second part of the series paper, we highlight the existing stroke systems of care in these countries, the various challenges in accessibility and availability of acute stroke care services, including acute reperfusion therapies, intravenous thrombolysis, endovascular thrombectomy, stroke units, and rehabilitation. For example, the lack of established EMS services or pre-hospital notification in most SEER countries, the highly disproportionate accessibility to IVT and EVT in many countries, and the still complete lack of it in a few. Our review illustrates how stroke care in the SEER has consistently improved over the years, but there are still wide gaps that need to be addressed and bridged. A holistic approach with active involvement of stakeholders, prioritizing cost-effective efforts with the largest gain, such as infrastructural reorganization, capacity building, and adopting alternative models of stroke care is the way forward.
Post-stroke rehabilitation in the Southeast Asia region faces significant challenges due to various factors like the government's focus on acute care, availability of medications, so on and so forth. However, stroke in these regions contributes largely to disability-adjusted life years, years lived with disability among all the other NCDs. Unique issues exacerbate the challenge of accessibility and utilization of stroke rehab. For example, in Sri Lanka, it lacks adequate follow-ups, favoring men. Bangladesh, on the other hand, heavily relies on costly private rehabilitation services, just like in our country, India. In Thailand, post-stroke rehabilitation varies widely, with physiotherapy being most commonly available with respect to the other disciplines of rehabilitation. A shortage of trained rehab staff workforce hinders early utilization of rehabilitation service in addition to the belief in traditional medicine in such countries. There is a need to improve awareness, stroke workforce capacity, and quality of research in Southeast Asia region, focusing on implementation study designs, cost-effective strategies, multidisciplinary care, and influence on policy.
Stroke care in the Southeast Asian region requires improved availability of services and quality of care. The World Health Organization Southeast Asian Office collaborated with the Department of Neurology at Christian Medical College, Ludhiana, to provide technical support for stroke improvement initiatives in the region. Through this collaboration, we have worked with countries such as Bhutan, Maldives, Myanmar, Timor-Leste, Nepal, and Sri Lanka. We were able to set up 3 stroke units in Bhutan, develop national stroke protocols for Sri Lanka and Nepal, develop case record forms for the stroke registry. We have trained over 150 stroke care professionals and certified 56 of them through over 47 online training sessions. Currently, we are working on the implementation of stroke care services and establishing stroke units in this region. We intend to facilitate the NCD Regional Action for Southeast Asia 2013-2020 to reduce premature stroke mortality by 25% by the year 2025.
Stroke is a global public health problem, and more than 5 million people die due to stroke every year in the world. Monitoring and surveillance of stroke in Southeast Asia region countries is extremely important, as every 4th person in the world lives in these countries. Stroke surveillance involves monitoring new cases of stroke, those who have died due to stroke, and those who are surviving with stroke. We conducted a systematic review of published literature over the last 25 years to assess efforts for stroke surveillance in these countries. We found very little primary data on stroke surveillance in these countries. National efforts for stroke surveillance were only available in India and Thailand, while Bhutan, Maldives, and Timor-Leste did not have any published data on stroke surveillance over the last 25 years. Efforts for monitoring of stroke risk factors were also minimal. Our systematic review identified glaring gaps in stroke surveillance in Southeast Asia region countries. Efforts are urgently needed to build the capacity for stroke surveillance, initially starting at the hospital level and eventually going to the population level. In order to reduce the burden of stroke in Southeast Asia region countries, it's extremely important that surveillance of stroke and its risk factor is done and its capacity is built over time.
An integrated approach is needed to reduce the burden of stroke in CR countries. Establishment of stroke units and access to time-sensitive treatments like intravenous thrombolysis, mechanical thrombectomy are crucial for each country. Training and capacity building are essential for all the stroke healthcare professionals. There are several models of stroke care available in the region which could be implemented. There is an urgent need to develop and strengthen stroke rehabilitation and community integration. The government should invest on a robust surveillance and monitoring systems. Implementing population-level prevention programs using digital technology is the way forward to reduce the incidence of stroke in the region.